Welcome everyone to the joint eMedica and Medical Protection Society MRCGP AKT Essentials webinar on keys to success in the AKT. So for those that haven't met me before, brief introduction. My name is Muhibur Rahman. I'm a portfolio GP, which means I'm a GP with multiple roles. So my clinical roles include being a partner in my own practice. I work as a locum in various other practices, and I work in community detox. Most of my time now is spent in medical education as medical director of eMedica and a consultant in medical education. Did my GP training in Neath Port Talbot in South Wales, passed my MRCGP with merit back in 2007, and I got FRCGP for my work in medical education and humanitarian medicine about 10 years after that. I've been teaching and writing on MRCGP now for over 20 years. I'm one of the authors for the Prescribing Safety Assessment, and I've written and edited various MRCGP resources for AKT all the way up to SCA and careers. I sit on the NICE GP reference panel, and our team at eMedica have trained over 83,000 delegates since 2005. Let's go through the learning objectives. So by the end of this session, what will you know? What will you have covered? Well, you should know exactly what to expect in the exam, including the new changes that are starting from later on in 2025. You know how to prepare effectively. Know what are the common things that can lead to people failing and how can you avoid them? And the opposite. What are the habits of those that don't just pass, but smash the exam with the really high scores? And perhaps if you emulate those can act as keys to success in the exam. Well, you'll also know what are the things that we offer, courses and resources to support you with AKT. And it will be a chance for you to kickstart your AKT preparation. And if you hang around to the end, we'll also launch a special offer for anyone that wants to book any of our courses and resources. Okay, good. So let's start with an overview of the exam. So you can sit the AKT, which stands for Applied Knowledge Test, in the second year of GP training onwards. So you've got to be an ST2 to sit the exam, and it's available 4 times a year. So if you think that most people start in October, the academic calendar for exams runs October, then January, then April, and July is the final exam. So for those of you that started training prior to August 2023, there's a maximum of 4 attempts with 1 exceptional attempt in specific circumstances. For everyone that started 2023 August onwards, you're allowed 6 attempts to the exam. Now, the big change that's happening from the next exam, the October exam, the July exams just happened. From the October exam onwards, the exam is changing in terms of question numbers. It used to be 200 questions before. It will now be 160 questions in 160 minutes. And you'll sit it at a Pearson VUE Test Centre, the same places where you went to do your MSRA, but only within the UK. Everything else about the exam has stayed the same. So the proportion of questions in the 3 domains stays the same. So 80% will be clinical medicine relevant to UK general practice, 10% will be evidence interpretation, so stats, evidence-based medicine, and 10% will be the organizational or administrative and health informatics domain. The main format, about 85% of the questions are made up of 2 types, extended matching questions and single best answer questions. That's the bulk of the questions, and you're already familiar with those. But there are lots of other formats in the AKT. So the other sort of 15% or so of questions, they could include multiple best answers, where there's more than 1 correct answer. You have to get it fully right to get 1 mark. You get it half right, half wrong, you get nothing. There are no half marks in the exam. Algorithm questions, where there might be part of an algorithm from a guideline and some labels you have to drag and drop to the right place to make sure that you know that guideline. Picture questions, so they could show you a skin lesion, a fundoscopy image, an otoscopy image, an audiogram, an ECG, a blood report, urine dipstick, all kinds of things that you might see in a GP setting. And there'll be a case and a question attached to it. They might test knowledge of a specific seminal trial that's had a big impact on general practice. You could have a short answer question where there are no options to guess from. You type your answer, and video questions. So I'll make sure that you see examples of all of these formats by the end of this session so that you're familiar with the format. So in terms of the dates over the next 12 months, something really important to understand. As I mentioned, the exams are October, January, April, and July. But the new system that came in a couple of years ago means that you have to reserve in order to be able to book. For example, the reservation window for the October exam ends 2nd of September. Anyone that hasn't reserved a slot by then, when the actual bookings open from the 10th to the 12th, they just won't be allowed to book. And then the same for the others. So the reservation window tends to close somewhere between a month and a bit more than a month before the booking window, and then the results come out about a month after the exam. Now, this session is very interactive. So what we're going to do, we're going to learn, like if I just talk to you about the formats and I don't show you some examples, it can be a bit dry. So I'll show you some examples. I'll show you some questions. So if you write down question numbers 1 to 12 on a piece of paper at home, keep a note of your answers, and I'll tell you how to interpret it at the end. The way we'll do it is, you know, in the exam, you've got 160 questions, and for standard timing, you've got 160 minutes. That gives you a minute per question. But if you go at that pace, you would finish the last question just as the buzzer sounds. That doesn't leave any time for some questions that take a bit longer, or any questions that you flag and you want to go back to later because you guessed it or you really weren't sure. So what I'm going to do is I'm going to get you used to the optimum pace, which is if you go at 56 seconds per question, you will build up about 10 minutes to go over any that you're unsure of at the end. So I'll show you a question. You'll have 56 seconds to look at it. Then I will launch a poll. Once the poll goes up, you've got 10 seconds to pick something on the poll option. And then we'll go through the answers, explanations, and some teaching. Because I think if we've done some questions first, then if I talk about how to prepare, why people might fail, and how to do really well, it will make much more sense to you because it won't just be abstract. So let's get into it. Here's the first question. You've got 56 seconds. Now, you see, this is an example of a multiple best answer. You see, it asks for two, which two of the following? So you've got someone confirmed to have stage 1 hypertension, and we're now looking at stratifying their risk further, okay? And so if you get one right and one wrong, you won't get any marks. There's no half marks. You've got to get both options right. So this type of question adds significant challenge. So the correct answers are B and H. Now, what's interesting is that lots of you had H as one of your options, but very few of you had B as your second option. Lots of people picked A, for example, urine dipstick for proteinuria. You need to send urine to the lab to look for proteinuria and also to do albumin creatinine ratio. So sometimes it's a small thing as reading carefully the answer option, that one word, rather than urine dipstick. If you said lab urine for proteinuria or for albumin creatinine ratio, that would be part of the correct answer. So very few people got both B and H. Lots of you got one or the other, but hardly anyone would have got a mark from this question because you need to get it fully right to get the 1 mark, okay? So once we've confirmed a diagnosis of hypertension, the reason that we want to do further investigations is that hypertension is one of the major risk factors for cardiovascular disease, right? So what we want to do is further stratify that risk to see if there's anything modifiable that we can target. But we also want to see, is there already an established target organ damage? So you can dip the urine for hematuria. Blood shows up very well on the dipstick, okay? You need to send lab urine for albumin creatinine ratio and to look for proteinuria. Dipsticks aren't reliable for that in this context. You also need to do bloods to check renal function, including EGFR, to check for diabetes. So you can do that with HbA1c, and to check lipids. You should check the fundus to see if they might already have some hypertensive retinopathy, so evidence of end target damage. And then 12-lead ECG. What might we be looking for on a 12-lead ECG? Let's say someone's had hypertension, you know, we call it the silent killer. It's asymptomatic in lots of patients. What may they already have had going on for, you know, if they've had high blood pressure for a couple of years, what could they have developed as a result of the body having to deal with that? Yeah, what we're looking for in the ECG is changes of left ventricular hypertrophy because of that added work that the ventricle's doing, pushing against that increased resistance, that increased pressure. Okay, excellent. Good. And just to highlight that you can have the knowledge and still lose marks if you have poor exam technique, that reading both the question carefully and reading every bit of the answer options carefully. So do you see, urine dipstick for proteinuria, the reason this is wrong is not that we don't test urine, and it's not that we don't look for proteinuria. We do, but you need lab urine, not dipstick for that. Similarly here, we don't do retinal imaging for hypertensive retinopathy. We just look at that ourselves, fundoscopy. Only if we saw something worrying, we might need to refer someone on if they needed treatment. But you're not going to send everyone with hypertension for retinal imaging. The system couldn't cope with that. And ABPI measurement, that would be if you suspected peripheral arterial disease, not for someone just with hypertension. Okay. Let's move on to question number 2. Here's an example of a video question. It has no audio. Okay, great. So very interesting. The most popular answer by a large margin, most of you picked A, prednisolone for 10 days. Okay, and it's actually a two-step question because the question is asking about the most suitable management. But to get that right, you first need to think, what's the likely diagnosis? So type that into the chat. What if the question was asking, what's the likely diagnosis based on what you've read and what you've seen in the video? What would you put? Yeah, this fits with Bell's palsy, doesn't it? You know, if they'd had weakness or slurred speech, then we might think maybe they've had a stroke or a mini stroke, right? Depending on how long they've had it for 10 days, then it'd be a stroke by definition, right? Because it lasted more than 24 hours. But in the absence of those things, it's a young patient as well. This fits with Bell's palsy, right? As the diagnosis. See, in a two-step question, the first step is usually very straightforward. They're not trying to catch you up. So what is important though is there's the knowledge side, knowing the guideline, and there's technique, reading carefully. Do you notice she's had the symptoms for 10 days? That's why we've missed the window for prednisolone. The window for that is 72 hours. So the right answer is E. No medical treatment is needed for this patient. Okay, as we've missed the window for pred, it's just highlighting that most patients will make a full recovery within 9 months, and just to keep an eye on it. Okay, now what's interesting is hardly anyone picked that option. And the examiners have mentioned this. Less than a quarter of you got this right. So most people picked prednisolone. You might have missed that she's had symptoms for 10 days, or you might not have known the guideline that the window for that is within 72 hours. Quite a few people also picked acyclovir. There's no evidence base for monotherapy with acyclovir in Bell's. There is limited evidence for using acyclovir and prednisolone dual therapy, but again, only if you catch it within the first 72 hours. So that option is also wrong. And this patient doesn't have any of the indications for referral for ENT. Type into the chat, what are some of the things in relation to Bell's palsy where you would refer to ENT? And then just really in terms of technique, the examiners have highlighted this, that sometimes in GP, we watch and we wait. We don't need to do any active management. And just like it is in real life the case, in the exam, sometimes that's the answer. But there's some people that they think, oh, that seems too straightforward. They don't want to ever pick an option of basically do nothing. And then even though that's what they were drawn to, so there might be some of you that thought, actually, yeah, this fits Bell's. We've missed the window for treatment. She seems like she can open and close her eyes, so no treatment's needed. We just need to keep an eye on it. But even though you're drawn to that, you thought that seems too easy. They're trying to catch me out. And you changed your mind. Even though E was what you were drawn to, you then changed it to one of the others. And you actually changed the right answer for a wrong one because you didn't have confidence in your own knowledge. You didn't trust your gut. Okay? Is anyone that happened to? That you basically didn't want to pick option E because it seems too easy, and or you felt you should never pick do nothing. But that's what we do in a lot of real cases in real life. There is no need to do any active treatment. And so if it's the right thing in real life, it's the right thing in the exam. Yeah, so some people have done that. Yeah, quite a few people actually said that. Okay, great. So Bell's palsy, an acute, one-sided, usually, idiopathic facial nerve paralysis. Most patients will make a full recovery within 9 months. And if we catch them in the first 72 hours, then giving prednisolone can improve the recovery speed. If we've missed that, then unless there's a reason to refer to ENT, we don't need to do any active treatment. We'll just keep an eye on them. Tell them if they've not resolved, come back, or if they develop new symptoms, come back. Now, when should we refer to ENT? If they've got bilateral bells, which is very uncommon. If they've got recurrent bells, if the diagnosis is unclear and we're really not sure what's going on, or if after 1 month they've not made any improvement, we're not expecting a full recovery, that can take much longer. But if after 1 month there's not any improvement, again, we'd be worried about that and would want ENT to have a look at it. Okay, good. Question number 3. Now, this is an example of a free text question. Do you see there's no options A, B, C, D, E, F, G? So when you're ready, type your answer into the chat for this one. And that's what you do in the exam. You would click into the box and you would type using the keyboard. Okay, so first thing, there's 2 really important bits of learning here. Okay, a seminal trial is a trial that's had a large impact on general practice. Okay, in the context of this exam, that's what it means. So there's lots of trials that have had a big impact on general practice. But the other bit is about the wording of the actual question. Do you see it says, what is the name of the study? It's not asking what type of study is being described. They've already told you what type of study it is. It's a prospective cohort study. That's the type of study. Do you see? That's already given to you. So if you were to type that in here, you get no marks for that because they told you it's a prospective cohort study. They're describing a specific prospective cohort study that started in 1996. It's still ongoing now, actually. And that these were the main findings of it. And they're asking you, what is the name of that study? This is testing knowledge of a specific seminal trial. The name of that study is called the Million Women Study. It's one of the largest data sets ever assembled. They recruited over 1 million women in the 90s, started in 1996, but they started recruiting before that. Okay. I remember this study because that's the year I started medical school, 1996. Okay. And they were recruiting for this study then. And about half of them were on HRT, about half of them were not on HRT. None of them had breast cancer at the start when they recruited them. And initially, what they were looking for is, does being on HRT have an impact on rates of breast cancer and on outcomes? And that's what they were initially looking for. But because they had such a large data set, they said, well, let's track other things. Let's look at ovarian cancer, cervical cancer. Let's look at stroke. Let's look at heart disease. Let's look at osteoporosis, dementia. And because they had such a large data set, they basically expanded it out to look for other things. Okay, so this is an example of a seminal trial, a specific trial that's had a big impact on general practice. This is the trial that gives us the information that we have about the risks and benefits of HRT. And lots of studies since that have then fine-tuned different types of HRT. They're based on some of the learning from this initial study. Okay, but so there's the knowledge side. But the second thing I just want to highlight is that the technique, that if you answer the wrong question, if you're answering what type of study it is, you're not going to get any mark for that, even if you get the type of study right, because they gave you the type of study. It's a prospective cohort study. Okay. You can see the question was asking for the name of the study, not the type of study. Okay. Right. Let's look at a picture question on eyes. This one's really, really interesting. So there's a two-way split between E, external sty, and G, meibomian cyst, with external sty being slightly more popular than this one. So this was the most popular answer, E, followed by this one, then followed by blepharitis. Okay. Now, in any picture question, really important part of technique is make sure you look at both the picture and read the scenario. Because if you just look at one or the other, it's very easy to get it wrong. So if you look at the picture, you can see that there's a swelling here. There's a little bit of redness just around there. But look, the rest of the upper eyelid, the lower eyelid, fine. There's no crusting here. So it's not bacterial conjunctivitis. This isn't even red. All right. So an external sty can look like this. All right. But now we look at the scenario. There's minor irritation, but no pain. On an examination, the lump's non-tender. That's why the right answer has to be meibomian cyst. And I know that it actually is because I know where this image came from. And the doctor that provided this image also provided the actual diagnosis. Okay. So can you see, just looking at the picture, you can't actually easily separate these two. They can look very similar. The way you're going to separate it is that a sty is usually very tender on examination and is usually painful, whereas meibomian cysts, also known as chalazion, they tend not to be painful. They often are irritable, but they're not painful, and they're non-tender on examination. That's the key. This non-tender, and there's no pain. That's why it's this, not this. Now, if you just looked at the picture, it'd be very easy to think because external sties can look exactly like this. Okay. So a meibomian cyst, also known as a chalazion, a sty is something entirely different. This is chronic inflammation and blockage of the meibomian gland. So usually it's not painful, it's non-tender on examination, gets better on its own, but you can sometimes make it a bit more comfortable and speed it up with things like massaging the area and a warm compress, so conservative management. You wouldn't give antibiotics unless they had a coexisting conjunctivitis that looked bacterial, in which case you would give it to treat that, not to treat this itself. And if they're not improved on conservative treatment after 4 weeks, then you would think about referring to ophthalmology. Now, this one is an example of an algorithm drag and drop. So in the exam, you would pick the ones that you want and drag them here and here. You'd have to get them both right to get the 1 mark. So when you're ready, type into the chat stroke risk and what you drag and bleeding risk and what you drag. And I will imagine you've dragged, and I'll show you how you'd actually drag it in the exam. Okay, great. So well done. So what you would do in the exam, you would take Chad's VASC and drag it to under stroke risk. And then you would take Orbit and you drag it to bleeding risk. And you need both right to get the 1 mark. If you've got 1 right and 1 wrong, you get nothing. Equally, imagine someone, they didn't actually drag it. Instead, they clicked this, then clicked this. Then they click this and they click this. In their mind, I've clicked the right answers. You won't get any marks for that because they ask you to drag the label, not just to click it. So this is, again, an example of exam technique. You can have the knowledge and still lose marks. Okay. So Chad's VASC for stroke risk and Orbit has replaced Has Bled as the recommended tool by NICE to assess bleeding risk for those that are at increased risk of stroke and we think of starting an anticoagulant. So this is Chad's VASC and this is the Orbit bleeding risk score. These two are taken from our clinical case cards, which is an efficient way to sort of revise lots of clinical guidelines. So the clinical questions, as we've seen, they might relate to disease factors, risk factors and how things present. They might relate to making a diagnosis. They might relate to what investigation you might do or interpreting an investigation finding that they've given you. They might relate to management plans, including knowing who to refer, who to admit, who's an urgent referral, who's a non-urgent referral, who we don't need to do anything for. Some might specifically test knowledge of prescribing, and others might test emergency care in general practice. And the questions are going to be a mixture of, those things that are about low impact but common conditions. So, we probably see musculoskeletal low back pain most weeks. In the winter, you probably see a viral sore throat several times a day. You might see a back pain that's called equina once or twice in your career. You might see a sore throat that's actually a head and neck cancer a couple of times a year. Those are, much, much rarer, but much higher impact. They'll test both. Common reasons for consulting. There's never been an AKT that has not had questions on contraception. It's a common reason that people go to see their GP. Okay. Questions about sick notes in the admin domain. Again, that's a common thing that people come to see their GP for, to get signed off. And then areas that have been identified as problems in the past by examiners, they will always retest them. But also, if we look at exam stats, you can see which areas people do worst in and try to master that. So we'll cover that in a minute. So the pass mark and the pass rate for each exam sitting is variable. It's what's called a standard set exam. So when they set the questions for the exam, they set what pass mark they will set based on how hard is it. So if the exam has slightly harder questions, they lower the pass mark. If it has slightly easier questions, they increase the pass mark. This is done before anyone's taken the exam. It's based on how hard the questions are when they set the exam. If lots of people in your cohort do poorly, there will just be a poor pass rate for that sitting. They don't adjust based on results. Okay. Now, after the 7th sitting of the AKT, they decided that they wanted to increase the pass standard. And since they did that, the pass rate dropped. So if we look at, I've kept record of every AKT ever. The lowest the pass mark has ever been set is 66%. The highest is 72.5%. The long-term mean is 69%. And if we look at the pass rate, the long-term mean is about 71%. But if we look at the last sort of 3 years, the pass rate is 67%. I.e., about 1 in 3 are failing if we look at the last 3 years worth of data. The exam has become objectively harder. And what we notice from the report, the admin domain is the one that people score lowest in on average. So now we did one question at a time, and a lot of our webinars, that's how we teach. We go through one question at a time, then look at the answers, explanations, and technique. But at our AKT full mock grammar and our AKT full day preparation course, we have some questions like that, and some questions we do in the form of mini mocks. So I want to give you a chance to also do some questions as the form of a mini mock. So you'll see questions 6 to 12. So that's another 7 questions. They'll automatically move forward every 56 seconds. So write down the question number, write down your answer. I won't launch any polls for this one. After we've gone through all of them, I'll go through the answer and explanations. Okay. So here we go. The questions will move forward automatically. You won't see or hear me, but I'll be here monitoring the whole thing. Here we go. Well done, everyone. We've finished. So let's go to the answers. So this is an example of some of the new style data interpretation questions that they use in the stats or evidence-based practice domain. So these are actual data that I've pulled from Public Health England. Okay. And so these are different parts of London. London is the region. And the question's asking for the worst infant mortality rate. So common mistake here is people look at this. The count is the number of actual deaths. So you can see that Croydon had 72 actual deaths. So within London region, that's the highest because they've sorted it by that. But what they're asking for is the infant mortality rate. That's this number. The value is the deaths per 1,000. Okay, so infant mortality, deaths up to 1 year old. So the correct answer is D, Lambeth. You can see Lambeth had 4.7 deaths per 1,000. If you just look at the bar chart, it's the longest one. Okay, but you can confirm it by looking at the numbers. It had the highest value. The count is not important because these different areas have different numbers of population, right? And what we care if we want to compare is how many deaths per 1,000. That's a standardized way to look at infant mortality. Okay, so D is the right answer. So that's the number of actual deaths. A different question might ask, which area had the lowest number of deaths? That's Barking and Dagenham. They had only 40 deaths. And of course, we'd like the number to be 0. But sometimes babies might pick up a congenital infection. There could be complications during the actual birth. There can be trauma. Different things can happen. Okay. Gestational diabetes. So key thing, postnatal testing confirms she hasn't got actual diabetes. She was confirmed to have gestational diabetes. It's her first pregnancy. So in terms of screening, what the guideline recommends is to continue having annual screening. Generally, we'd use HbA1c for that. Okay. So common mistakes, people think because we use OGTT for gestational diabetes that they should be screened with that. Why are we using OGTT to confirm gestational diabetes? Because HbA1c is not accurate in the pregnant state. Yeah, absolutely, right? That's why. But it's a much more involved. You have to send someone to the hospital for this. HbA1c we can do in GP. It's very straightforward. Okay. And the reason these ones are incorrect is because they mention no need for regular screening after initial check at different periods. It's ongoing screening once a year because a proportion of these patients who develop gestational diabetes will go on to develop diabetes mellitus. We want to pick it up early. Okay, so it's a risk factor for diabetes mellitus. So postnatal check happens anywhere between 6 and 13 weeks. If it's before 13 weeks, they'll use fasting glucose. If it's after 13 weeks, you could use that or you could use HbA1c, but not OGTT, is not routinely recommended. And then ongoing screening with HbA1c. Pain management. So type your answer into the chat. What did you write down? Okay, because it's a free text box. In the exam, you would be actually typing your number, your answer into the box. Okay, now something really important here. 2 things. Although they're on diclofenac and paracetamol, they're irrelevant to the question because the question just asks, what's the morphine equivalent to the 24-hour dose of tramadol? So we just need to look at the tramadol. And on tramadol 200 modified release twice daily. Now, if you missed this and you just did a conversion based on 200, you're going to get the answer wrong. So that's technique, reading carefully. So 200 twice daily is the 24-hour dose of tramadol 400. What's the conversion? Tramadol to morphine? Tramadol is 10 times weaker. So all you do is drop a 0. So 400 milligrams of tramadol is equivalent to 40 milligrams of morphine. Okay, so 40 is the answer. 40 milligrams is equivalent to their 24-hour dose of tramadol. Okay. If you wrote any other number than this, you wouldn't get the mark. These don't get looked at by humans. It's marked by computer. So they're looking for the number 40. Now, if you typed out 40 milligrams, all the common misspellings, the common ways that people might write it, they accept that. They already programmed that in. But the key is that you've got to have 40 and milligrams in one form or another. Because if you put 40 grams, that is way too high, isn't it? Okay. For example, if you put milligrams and you typed it rather than put mg, they'd accept mg, they'd accept milligrams. If you mistype milligrams, sometimes people might put one too many L's. You're still going to get the mark. Okay. How do we get that conversion? It's directly from the BNF. There's a conversion table for opioid conversions. Morphine 10 milligrams is the universal opioid given orally. Morphine by injection is twice as strong. So 5 milligrams of morphine by injection is equivalent to 10 milligrams of morphine orally. Oxycodone is about 1.5 times stronger, so 6.6 milligrams of oxycodone is equivalent to about 10 milligrams of oral morphine. Diamorphine is about 3 times stronger, so about 3 milligrams is equivalent to about 10 milligrams. And then tramadol and codeine, they're both 10 times weaker. 100 milligrams of tramadol is equivalent to 10 milligrams of morphine. 100 milligrams of codeine is equivalent to 10 milligrams of morphine. Okay. Right. You see this patient, because I've had 3 readings on the same clinic visit as part of an NHS health check, you get called for this once you hit age 40. And it's, to look for risks and try to pick up things that we could maybe either prevent. So you might find someone's overweight but not obese. You could talk to them about getting to a healthy weight and the risks if they become obese of developing things like diabetes, high blood pressure, and so on. But you also might pick up someone who's got a diagnosis of something. Now, you're going to take these 3 readings. You will actually only document one of these numbers on the record. Which one would you document? Type into the chat. You're going to document 118/70. That's because what the guideline recommends is if the first one is 140/90 or higher, you have to do at least one more. What we all hope is that the first one's normal. Then you just write that down. You don't really want to repeat it again and again. But if the first one is not, it's 140/90 and above, you have to do at least one more. If that second one is significantly different to the first one, you then need to do a third one. You then ignore number 1. Out of 2 and 3, you document the lowest one. That's this one. How would we classify this number, 118/70? This is normotensive. And so what does the guideline recommend in that situation? There's no need to treat someone as normotensive, and you could repeat it within 5 years. So F is the right answer. Okay. So up to 3 readings to document 1. All right. You document the lowest of second and third if you're having to do 3. And if that number is under 140/90, that's great. That's what we want. They're normotensive. Repeat it within 5 years. If it's 140/90 or more, you'd offer ambulatory blood pressure monitoring or home blood pressure monitoring to confirm a diagnosis of hypertension. If it's 180/120 or more, then depending on if they've got additional findings or not, you might consider either immediate treatment or even referral to hospital if you're worried about things like pheochromocytoma or malignant hypertension. For example, if someone's got 180/120 and then you see retinal hemorrhages or papilledema, you'd be really worried. And so you see, because the first one was abnormal, that's why we do number 2. That's quite different to this one, so we do a third. Okay. Now, this one's a 2-step question. Question's asking about management, but to first get the management right, you want to first get the diagnosis right. Type into the chat, what's the likely diagnosis based on this description and this image? And this is, you can see, 1 of 2. This is a set of extended matching questions. They come in sets of 2, 3, 4, or more. Okay, so someone suggested it could be vitiligo. Someone else has thought that it could be pityriasis versicolor. Someone else has thought it could be seborrheic dermatitis. Someone else thought it could be tinea. And you see, depending on what you think, if you get the diagnosis wrong, you may well get the management wrong. So this is versicolor. Okay, pityriasis versicolor. Versicolor literally means multicolored. You can see there's different colors here. You've got, this is like a cream color, this one's more pink, this one's a bit darker, different colors. And then from the description, the fact that not painful or itchy is important, because things like tinea, one of the defining features of that is usually that it's very itchy, isn't it? Do you see, sometimes there are things that can look similar. This is why you must also look at this and combine them. So because it's pityriasis versicolor, that actually doesn't respond to things like terbinafine. It responds very well to ketoconazole, which you could use as a wash. Okay. Second one in the set. Again, what do you think the diagnosis is? And then we'll look at the management. So if we look at the picture, this is the abnormality here. And then if we look over here, itchy on the arm and in the groin. Okay. So yes, so this fits with ringworm, right? Tinea. And so terbinafine would be suitable for something like this. Okay. Great. Last one is from the admin domain. So it's about the GP contract. So what's the most common contract for NHS GP practices? And with nationally agreed terms, it's the GMS contract. Common mistake with this, a lot of people, if they really don't know this subject, they pick GPMS because it sounds like general practice medical service. That sounds logical, right? For the most common GP contract. But actually, this is a made up. There is no such contract. The contracts that do exist are GMS, PMS, PCLMS, and APMS. These are the 4 types of NHS GP contract. Okay, so GMS, General Medical Service, is the most common. It's a nationally agreed contract. You have 3 levels of service. Essential services, all GMS practices have to provide. Additional, usually you provide it, but you can opt out and you lose some funding. And enhanced, you might be able to opt in for extra funding. Okay, so add up your score. So we did 5 questions one at a time in the first half. Then we did another 7 in the mock. You get a total out of 12. I'll give you a few seconds just to add that up. And then I'll explain what that would equate to if you were sitting the exam tomorrow. You're not sitting the exam tomorrow, so don't worry. But just so you get an idea. And then I'm going to talk about why do people fail? What are the habits of high scorers? What do you need to do to prepare and to succeed? So 10 or above is excellent. That's a really, really good score. You know, that's a great stage to be at, given that a lot of you haven't started any active preparation. Okay. 9 or over would be just into a pass. It's above the highest that it's ever been set, because that's 75%, the highest so far is 72.5. 8 is borderline. In most sittings, this would be a fail. But in 1 or 2 sittings, when the pass point was set at 66%, it would just about be a pass. But in most sittings, this would be a fail. Okay. 7 or less, don't worry, that wouldn't be a pass in any sitting, but you're not sitting the exam tomorrow. Okay. So let's look at what are the common reasons for failing. And this is based on reading examiners' reports for nearly 20 years now, and our own experience. eMedica now has been running, it'll be our 20th year next month of running courses. All right. And so over that year, you know, we're at 83,000 delegates now. We've got a lot of expertise and experience in helping a lot of people who are resitting. We often help, but we also love to see people that want to pass first time, that come early. And over the years, we've collated feedback and we've done our own research on what are the things that are common in people that fail, and common in people that sometimes fail multiple times. So I'd say one of the really common ones is that they rush to sit the exam or they rush to resit. So you get some people, they get it in their head, I've got to sit it in the October of my AKT2 year. Now, that might just not be a good time for you. For example, if you're going to be in a really busy rotation like emergency medicine, you've got lots of nights, lots of evenings, weekends, you might not have that much time to study. And when you're doing a shift like that, you basically get no rest, right? Beyond your mandatory break. And sometimes that doesn't even happen. You're never going to be sitting around, right? You're seeing one patient, there's another patient, there's another patient, there's another patient. So sometimes you come home, you're just too tired to study. Do you see? Much better to prepare when you're in a GP rotation, when you generally, apart from a few out-of-hours shifts, and you might do the odd extended hours, but then you get time off in lieu, you don't have evenings, nights, and weekends to worry about. The day work is intense, but you know, you can at least plan, okay, I can do this much each evening, I can do this much on the weekend. Easier to plan. Similarly, if you're doing something like peds, it's just really busy. Equally, there might be things outside of work, like if you've got a family wedding coming and you're really involved in, you know, help to organize and things like that, that's going to leave you less time to study. You know, it might not be ideal. If you've got a big holiday planned, you know, you're going to go to your dream destination for a 2-week break. You don't really want to ruin that by having to being studying every evening. But equally, if you lose 2 weeks where you can't study at all, that's going to have a serious impact because the curriculum's huge. And that leads into number 2, which is just not allowing enough time. So, you know, people that either start late, don't recognize how large the curriculum is, don't recognize the level of it. Because some people, they might themselves, or they might know a friend who crammed for MSRA in a month or less and actually got a really good score. But the level of that exam is the level of an F2. It's very, very basic in terms of difficulty. Okay, they're just testing broad knowledge. Here, they're testing broad knowledge in depth. They expect you to know doses of common drugs that you'd prescribe in GP, for example. You know, it's specific. It's a much, much more challenging level. So, you know, you need to cover the whole curriculum, admin, stats, and clinical. But clinical, you have to recognize how big that is. Such a big curriculum, you need time. And finally, not up to date with recent guidance. So sometimes people will be answering questions based on something that they've read maybe for finals or for MSRA, but it's a couple of years later and the guidelines change. For example, just in the last year, we've had new or updated guidelines on asthma, on obesity, on menopause and HRT. You know, so many things change and the exam is updated regularly to test the latest guidance. Focusing on just one source of learning. So for example, sometimes someone will pick a question bank, and a question bank will be a big part of your preparation. But if all you do is rely on one question bank and repeat the same questions multiple times, what happens is you learn the questions off by heart. You haven't learnt the subject. You get a false sense of security. You think you're faster answering the questions than you will be when you're seeing new questions. And then they go from fifth sitting of the same questions, I was on 99%, they get to the exam and they fail. And they think, what's happening? Having poor confidence with stats and admin. While these two together are 20% of the exam, if you can learn them well and get more than 80% in stats and more than 80% in admin, you can get away with 75% in clinical. If you don't overcome, and some people find stats challenging, they find admin boring, but if you don't overcome that and learn these things, the only way you're going to pass is by getting a really high score in clinical. Lastly, poor exam technique. And we saw some examples here where you might have not had the knowledge, but if you misread an answer option or misread the question, one small keyword, it might make the difference between getting the answer right or not. Time management. That's another bit of exam technique that can have a big impact, that people that don't manage their time well, and then they run out of time. They just don't see the last 10, 15 questions. So how to prepare for the AKT? Try to have as much active learning as possible. So for example, reading is an example of passive learning. It has its place. But active learning, like we did questions and then went through the explanation, that's active, okay? So, even when you read, you can turn that into active learning by summarizing your learning into your own bullet points. But a big part of your learning is going to be by doing questions. Allow enough time to prepare. The RCGP examiners say a recommended minimum is 3 months. To do it in 3 months, it's possible. We have a 3-month program, for example, but it's really intense. It means doing work every day. For most people, 4, 5, or even 6 months might be better. And if you've got a lot on, you've got young kids, you've got caring responsibilities, you've got a busy rota, you might need even more than 6 months. Focus your revision to maximize your marks. Look, stats and admin, only 10% each. Learn these well. You can get away with 75% in clinical. Ultimately, clinical is what will determine if you pass or fail, though, because it's 80% of the questions in the exam. If you don't get a good score in clinical, you could have 100% in stats and 100% in admin. You can't pass. Now, clinical is huge, so you need time. So the RCGP expanded the curriculum in 2019, and they made it bigger, essentially. And then they've had some smaller updates. That was like a big update, but they've had some smaller updates in the last couple of years. So all the questions are mapped to the curriculum, and it's a useful reference, but you can see it's a huge document. It's over 250 pages long. We've produced a concise curriculum checklist, which on our structured programs, our AKT Pass Plus and AKT Pass Guarantee program, you get the printed version of this to use as a physical checklist to make sure you're covering everything. And then high yield topics. So these are topics that appear a lot in the exam, that examiners have highlighted as weak and or important, and they frequently retest these. So after every exam, they publish a feedback report where they say what was the pass rate, what was the pass mark, and what were the topics that people either did really poorly in or that they're happy that they did well in. They're telling you, we're going to test these again in the next exam. And what I've done is I've compiled a checklist from all of the examiners' reports of the things that appear most often. These you absolutely must make sure you've covered. You can't just cover these. You have to cover the whole curriculum systematically. But in the last couple of weeks, go over stats, go over admin, go over these high yield topics, and you're going to have a good level of confidence when you go to the exam. If you want material to read, the Oxford Handbook of General Practice, a lot of people have anyway, day to day when they're in GP. It's a good section at the beginning on some of the admin topics, good section on emergencies. The only thing is, because it was published in 2020, so many guidelines have changed. The management part of a big chunk of it is now out of date. So you can't rely on it for those things. A new one should probably be coming in the next couple of years. What can be useful if you want to check things that are up to date, the BMF NICE have now taken that over, and they've produced treatment summaries for different conditions, which are up to date. If you want to look up a specific guideline, you could look up the NICE website and look at that guideline. If you want to cover lots efficiently, we have a clinical case card. So there are 112 topic reviews. We've got a print version, there's 56 double-sided cards. We've got a digital version. There's a bundle where you get all of them. And, we saw those pictures from Chad's Vascan Orbit. That's an efficient way if you want to cover lots of things. And in terms of practice questions, most people will use at least 2 question banks. So we've got a question bank that's mapped to the MRCGP curriculum. It's got over 2,300 questions. It's got similar layout to the real exam, but we've got high challenge questions. We're known for having slightly harder questions than the real exam. If you get used to the hard questions, the moderate level of challenge and the easy ones you'll walk, okay? And it's anywhere from £49 for a month up to £129 for a year. And you can see we map it to the same exact headings that the RCGP use in the exam. We've got dedicated section for admin questions and stats questions. There's mini mocks and a full mock as well. As associates in training, you all get access to the RCGP self-test, and I definitely recommend that you use this as one of your question banks. And if you want additional sources, other ones that have good reputations, Past Medicine and On Examination. Just to highlight, we've helped thousands of doctors pass their MRCGP exams over many, many years. But just, some examples of people who it was their first time and they passed. But look at this person. Their first time they failed. They went from 66 to not just passing, but smashing it. They were 82%. Okay. To people who, came first time and they found having a structured program, just, they knew exactly what to do. They just followed the daily email. They've got a timetable. They didn't have to worry about that. They just got on with the work. And then, they were well prepared. This was someone who's on their final attempt. Had they not passed this time, they would have been released from GP training, having done already more than 4 years because they've had extensions, and they would have had nothing and not been able to be a GP. First attempt or last attempt, we're here to help you make sure that the next one that you sit with us will be the one you pass. So what are the habits of high scorers? Because over the years, we've helped lots of people that have scored 90% plus. They're not just passed, they're right up there in the top few percent. I'd say these are the 7 keys that are common in those people that do really well. So number 1, they plan ahead. They think, in which rotation will I have more time to study? In which rotation will I have time to do the hours? When's the good time for me? And they sit it then rather than rushing. Number 2, they systematically cover the curriculum, whether that's joining a program like ours where we've done all of it for you, you just have to do the work, you will cover everything, or that they make sure they download the curriculum and they find a way to make sure they're covering it rather than just haphazardly hoping that they've covered the right stuff. Number 3, they understand the exam. So they understand the exam format, they understand the timing, they know what to expect. So there's no surprises on the day. Number 4, whether they like it or not, they put the hours in and they master stats and admin. They score 80% plus in these domains so they can get away with 75% plus in clinical. Number 5, they learn the subject, not the question. So rather than repeat the same questions 5 times, sometimes you've done a question back once, revising it a second time, maybe picking out some of the areas you didn't do so well in, that's fine. But by the time you're doing it a 4th and a 5th time, you're adding very little. You learn them off by heart. So instead of just learning the question, they instead learn the subject. Any they get wrong, they read up the guidelines. So they understand the subject, understand the guideline, but also they understand, why did I get it wrong? Number 6, they revise all the high yield topics because that's the examiner's giving you a clue. This is what's going to come up. Number 7, they work on exam technique as well as consolidating knowledge. You can have the best knowledge in the world. If you don't manage your time well and you don't answer the last 30 questions, you misread keywords, even with knowledge, you're going to lose marks. You need both, okay? So just to also say that we recently ran a similar session to this for SCA. Our MRCGP SCA Essentials webinar is already on our YouTube channel now, for those of you that are going to see SCA in the next 12 months, because some of you are doing both, okay? To summarize for AKT, that look, it's not enough to have knowledge. You need that as a base, but you need to be able to apply it in a context relevant to GP. So the questions tend to be a bit longer, not one-line questions, because there's a case attached to it. That the organizational area is the weakest, but if you can master that and you can master the stats, that can be some easy mark. Ultimately, you need to do well in clinical if you want to pass. And that examiner's feedback can be valuable for that last bit of revision, but you need a systematic plan to cover the whole curriculum if you want to be well prepared. Finally, allow enough time, because like anything in life, prepare and you will succeed. Okay. And finally, I leave you with this from Lao Tzu, that a journey of 1,000 miles begins with a single step. So I hope after today, you have a clear idea of what is the exam, what's the level like, how can I approach it, what not to do, what to do, and you've already done some questions. So you've started, you've taken the first step today. Just keep that up. Give a good amount of time, work consistently, and then as you get closer, build up intensity. If you can do all of that, then you will be prepared and you will succeed.